Dear colleagues, ladies and gentlemen, welcome back. And my name is Nicolas van Michem. I am an interventional cardiologist. I'm also the chair of TIO, and I'm so happy with the momentum that TIO USA has gained. I look forward to share this session where we will turn our attention to the mitral valve, exploring the full landscape of transcatheter mitral interventions from anatomical decision-making through expanding indications. It is my great pleasure to welcome our distinguished panelists. We have Andrea Scotti from Montefiore Medical Center in New York, David Daniels from California Pacific Medical Center in San Francisco, Neil Pham from St. Michael's Hospital in Toronto, Mark Russo from Robert Wood Johnson University Hospital in New Brunswick, and also Vratika Agarwal from Oregon Health and Science University, Portland. So welcome to the panelists. And we'll open with David, who will take us through a recorded demonstration of transcatheter mitral valve replacement. David, over to you.
Thank you so much, guys, for having me. We're going to present today a very challenging M3 case, TMVR. As I'm sure everybody knows, the M3 valve wrapped up the ENCIRCLE trial last year, and with really phenomenal results, we were able to demonstrate that we had a new therapy for patients who were unsuitable for commercial therapies. And then it was time to commercialize the device and apply it to the real world. So certainly going outside the scope of the patients that were in the clinical trial, we start to explore patients who really have no other options. And this was an example of a case that we did recently in our center. So I'll go through the case presentation first. So this was an 82-year-old with a prior M-TEER, actually had mitral clip in the lateral common A1P1, and that's going to be important when we talk about potential treatments for this patient with respect to TMVR. This was done just in January of 2025, so about a year before we saw the patient in San Francisco. She also had moderate MAC, which was part of the challenge. And you know, at the end of the day, many of us have treated patients with MAC with M-TEER, sometimes with very good results. But as we all know, the cases can be challenging, and the likelihood of a good outcome is significantly less than with the original degenerative MR population that we studied in the clinical trials with M-TEER. Currently, she had New York Heart Association Class 3 symptoms, really profoundly symptomatic, with about a half a block of exertion on flat land, and had a significant impact in her quality of life and activities of daily living. She also had a history of AFib and an attempt to improve her symptomatology, and due to really significant aortic stenosis as well, the referring physician actually did a transcatheter aortic valve replacement in August, which did improve things a little bit, but she still had persistent heart failure symptoms that she was referred to as mentioned above. So we saw her in December, and really there were only three options that we could think of, which were redo M-TEER, not feasible at all due to the elevated gradients at baseline in the MAC, and you'll see the images here in a moment and make your own assessment on that. She could have had a surgical mitral valve replacement. Certainly, I think that would be the only, sort of broadly available treatment for her. But due to her age and MAC and really pretty significant frailty, she had been in significant heart failure for some months. It was going to be really high risk based on the referring cardiac surgeon, physician, the cardiac surgeon at the referring institution, as well as our cardiac surgeons, and everybody agreed that was really suboptimal if there's something else that we had to offer for her. And the last would be M3. And I'll tell you that, not even close to meeting inclusion criteria for the ENCIRCLE trial. She had prior clips, which was a no-go. She also had a significantly, very small neo-LVOT, as we're going to see, and a very high risk for LVOTO. She would have gotten for sure screened out for both of those reasons from the ENCIRCLE trial. And so we thought, is there septal modification? Could we perform an elastic clip to manage the clips, or do something else? So that's where we were with her evaluation and trying to figure things out. So here's her baseline transesophageal echocardiogram. As you can see, she's got pretty significant MAC and fibrosis and a visually restricted orifice. You can see right here, there's one of the clips sort of sneaking up, and there's really one all the way in the commissure, and then one at A1P1 that was actually SLDA'd off the posterior leaflet that is likely responsible for what they initially got as moderate MR post-procedure, which was, I think, as good as they could have done based on the MAC anatomy and her gradient, but certainly transitioned, as you'll see here, to severe mitral regurgitation at the point at which we evaluated her. So, we have severe MR. We've got an elevated gradient, which was 5 millimeters of mercury at a heart rate of 60. We've got a well-working TAVR prosthesis, no problems with that. And we just sort of try to think, what is it that we could do? Is there anything that we could offer this patient? First thing we're going to look into is the CT. And as many of you, I think, are familiar with these analyses, one of the things that is probably is the biggest screen fail for TMVR technologies, and M3 is no different, is the room that we have in the left ventricular outflow tract. And we model the risk of LVOTO by putting an avatar of the valve in a position we think is pretty conservative. And then we trace the area in the left ventricular outflow tract. And as you can see here, it was very small. It was 140 millimeters square. The absolute cutoff for the Encircle trial was 150, but honestly, anything less than 200 would typically get screen failed as well. So the combination of the clips and that and everything, we really thought we were going to have to modify the septum. And we can talk about the options for that in a second here. So septal modification traditionally percutaneously has been alcohol septal ablation. I mean, frankly, we've been not really that impressed with it. It works sometimes if there's a septal in the right place. You certainly get heart block, not infrequently. Patient has chest pain, you're causing an MI on purpose. It sort of feels, for all these reasons, suboptimal. So, with the help of Jaffer and Adam and of the whole electrosurgical crew, we actually went out to Emory and observed cases some years ago and started to learn how to do sesame, and have brought it to San Francisco. So we performed a sesame procedure. That was the intention, to modify her LVOT, improve the LV outflow tract dimensions, and then proceed with dealing with her valve and the clips in some way. So I'm just going to start showing this very briefly. Here's the imaging, and imaging is absolutely critical in everything we do in structural heart, obviously, but I will say, especially when you're putting an electrified guide wire through the septum purposefully, and millimeters matter, whether you have a perforation or a VSD or a successful procedure. So it is really, really important. Mark Leben, that came to us from Columbia as our expert TEE operator. We could never do this procedure without him. And Mark is showing us, as he typically does, exactly what we need to see. You see the champ guide that we use crossing the TAVR valve, sitting right on top of the hump of the septum. And then we drive the guide wire, electrified guide wire, into the septum, and then we steer using fluoroscopy landmarks, and then sort of checking on TE and then redirecting as necessary. And, Mark shows us just absolutely beautifully here. You can see the wire cutting right through the important part of the septum as he sort of flexes that probe, a quarter millimeter or whatever it takes to show us exactly that path. And we're very happy with that. We try to target less than 50% of the septal depth that we're going to make the cut to decrease the risk of VSD, while also increasing the chances that we make a significant sesame to alter the LVOT dimensions. So let's see here. Next one. Okay, so post-sesame, we let the patient remodel, usually for about a month, and then repeat the CT. And you can see there is a dramatic improvement over on the right panel here. You sort of see the divot, and then most importantly, in the cross section, we now have a neo-LVOT of 400 millimeters squared. So absolutely no concerns for LVOTO. At least we managed that part. So the next question was what to do about the clips. We've done some clip removal. We've done a procedure called ElastiClip, where we detach the clips from the anterior leaflet. All of these things are electrosurgical facilitated procedures. To be very honest, the outcomes in our experience, and actually sort of globally with M3 and with other TMVR technologies for both, elastic clip and certainly removal have been a bit suboptimal in terms of outcomes. Sometimes you take a lot more of the anterior leaflet than you think, or the posterior leaflet, and you get a lot more MR because, especially with M3, we're relying on those leaflets to form a neoskirt and to cause a seal. So we collaborated with the Edwards team, did a lot of analysis, and thought, these clips are so far out there, especially the one in the commissure, but even the one at A1, P1, can we just encircle the valve and leave the clips and deploy? And we might have to plug, certainly, but we have, unfortunately, experience doing that. So we'll deal with it. And this patient didn't really have another good option, and trying to get these clips out just didn't really seem ideal. And we had an opportunity, because they weren't right in the middle, to try leaving the devices and just going around them and deploying the valve. So that's what we elected to do. Just to remind everybody, M3 as a technology is a two-step procedure. We start with placing a dock, which is facilitated by a hydrophilic sleeve around the cords and leaflets of the mitral valve. We then remove that hydrophilic sleeve, and then we deploy the dock. Once we deploy the dock, it's akin essentially to a mitral valve and valve procedure, where we're able to just deploy a balloon expandable valve as we would in a mitral valve and valve. Very straightforward from that point. It's really the dock that's the learning curve. But honestly, we've gotten this procedure down routinely to 45 to 60 minutes at the most, even in complex procedures. And this one was really kind of right in that range. I think it took just about an hour to do the case. So we start with a 3D TE view from above, and again, Mark is phenomenal at showing us. We always joke he shows us where to go with the X marks the spot, so we don't have to think too much. Puts it right on the medial commissure for us, and then we steer the delivery system to drop us right into the medial comm. And it's really important not just that we get into the medial commissure, but also that we sort of get into a chordal-free zone right in the corner to start our encircling. And that really optimizes the function of the dock, the paravalvular leak guard, which is on the dock, to prevent any PVL from the medial commissure. And I think getting that access right and making sure we start correctly has been very important with respect to outcomes for M3. So here's a real-time fluoroscopy of us encircling. We had just coming around to do the first turn here. That's encircling the lateral commissure and then coming down to the posterior leaflet to finish the first turn. And then I think here, we've played around a lot with fluoroscopic views, not going necessarily LAO or REO, but sometimes going AP. This is what we call the hybrid view. It kind of shows us both things at once. We've also played around with a technique which we used in this case. I call it the ski tip, where I essentially have the sleeve pulled back a little bit and allowed the dock itself to find the path. And the sleeve is a little bit farther back. Sometimes when the sleeve's all the way in front, it's kind of a blunt end and you'll hit something. But if you have the ski tip out, you grab, get around the obstruction, and then you still have plenty of hydrophilic sleeve in order to encircle the valve. So we've released the device here, and you can see that the dock is around the clips, and you see that MAC right there. The dock's all ready to go to receive the SAPIEN M3. Just as a note here, this is right after encircling. I think this is a beautiful demonstration of really seeing this sesame. If you look right here, you've got the notch in the myocardium, and you can see it on the X plane right there. And you see all that room that we created with the sesame procedure to prevent LVOTO. Here's a deployment, which is really pretty routine. We have a transeptal sheath, which is different than mitral valve and valve, and really allows us to get coaxial, which is great, and really control depth. We try to, be a little more atrial, especially if we're concerned about LVOTO, but I'm always fond of saying the valve finds its way to where it wants to go, and it's typically 50-50. We deploy the valve, and then we routinely do a double tap with +4 cc's. Oftentimes, if it's still underexpanded, and I think in this case it was, we'll actually take a true balloon and dilate it all the way. I think it's really important to have these valves fully dilated. In native MR without MAC, the +4 cc's does it 95% of the time. It's the MAC cases, and in this case, because of the one clip that was right next to the valve, we felt like we needed to dilate it fully. Really want to optimize valve function in the long run by having fully dilated valves. Here's a final fluoro. I think it's really cool to see where we are in 2026. All the structural heart devices in this patient. We had a pretty large septostomy. We ended up closing the septum at the end. I'd say we end up doing that maybe about half the time. So yeah, it's a cool picture. So here is the post TEE, and very typical. We just sort of see trivial PVLs that are sort of non-turbulent in the commissures. Actually, I think this is a good thing. You get a little bit of flow, much like the mechanical valves have a seating jet to wash the leaflets. I actually kind of like when I see this. But you do see that it's really single color, right? You don't see any aliasing. And I think in our experience, when you see this, hemolysis is never an issue. It's really when you have an angry jet of PVL that hemolysis may or may not be a problem, and you really have to pay more attention and follow up. Here's the 3D TEE. Always a beautiful picture to see, the result, and really give a high level overview. And you see we really resolved this patient's mitral regurgitation. She felt better immediately, which I have to say, especially for heart failure, MR treatment with low EF is not typically the case. This was a different situation. Her EF was normal. It was really a degenerative, leaflet problem. And she woke up feeling better immediately. And I think we were all really pleased with the result. Here was her LV outflow tract. There was absolutely no flow acceleration whatsoever. And in conclusion, in the modern era, prior clips in the lateral commissure, at least, we demonstrated, can be treated with M3 without removal with a good result, and that sesame is an effective mitigation strategy to prevent LV or TIO. We've probably done, 7 or 8 sesames in preparation for M3 and had really good results with the outcomes of those M3 cases. So I think it's going to be important, as we start to push the boundaries and look at patients that were not necessarily in the commercial experience. And I think that's it. Hopefully you guys can still hear me.
All right. Absolutely, David. That was a fantastic, spectacular case with a beautiful result. It definitely shows what we are able to do these days with in the structural mitral space. Maybe 2 practical questions. We see a lot of questions from the audience that relate to the anatomy, and obviously Vratika will dive into the anatomy in a second. But maybe a practical question to you, David. In terms of valve deployment, are you pacing on the wire or anything, or is it without pacing?
Yeah, we're definitely pacing on the wire, and we've always LV paced for TAVR actually, and for TMVR exclusively, essentially. It is something that's very, very important. Maybe you don't have to pace as fast, but to be honest, I don't get real fancy about it. Unless the patient's EF's very low, I pace the same as I pace for TAVR, frankly, up to 200 beats a minute. You don't want that variable involved with placement of the device.
Yeah. And I also saw you close the septostomy. Is that also your typical practice? You close it all the time?
No, we don't. And I think it's a really important area for a lot of reasons. We could probably spend 30 minutes talking about that. There's all sorts of issues, right? There's the reason we close. So an absolute indication is right to left shunting, right? And I think everybody would agree with that, right? So everybody's going to close that. But I would say softer indications, but more likely to push us to close would be if we have a significant sized ASD, and even if it's sort of moderately sized, if we have RV dysfunction already or TR, because those are the patients that have less right ventricular reserve, and a higher shunt fraction could be problematic. And the problem is they may have right heart failure symptoms, right, from their tricuspid or RV disease, and then they've got this shunt. It's very difficult to exclude that the shunt's not contributing to that. So I think from a practical perspective, those are the reasons we close it. The challenges with closure are twofold. One, reaccess, though in general, we use a cardioform device, which we and other people have had plenty of experience recrossing with electrocautery, and that's not usually too big of a deal. But the other is financial, right? So these ASD devices are another $8,000, and it's a capitated procedure. So already, I think all of you on this panel have probably been on the VAC committees trying to get M3 approved, and it's a struggle, right, with the price tag and the similar DRG. So I think adding an extra $8,000 to it is a challenge, but we do it when clinically necessary at this point. But we need to learn more about, frankly, when it's safe not to close. And it is a little different than M tier, right? M tier, sometimes you have a little residual MR, you're less likely to get right to left shunt. That's true, but also devices are bigger than the M tier devices by a couple millimeters, and that kind of gives you a little more pause when you're looking at the color.
All right. All right. Thank you very much for an excellent demonstration. Now we move on to Vratika engine making in mitral valve interventions. Vratika, over to you.
Okay. Good morning, everyone. Today we are going to talk about how anatomy plays into the decision making when we are starting to think about mitral valve interventions. Here are my disclosures. So anatomy is the first step in deciding what kind of intervention we are going to choose. We want to look at the leaflets themselves, if the leaflet tissue is adequate and healthy. We want to look at the MR jet, or if it's mitral stenosis, you want to look at the calcification, both of the annulus as well as the mitral valve. And you want to look at the entire structure in 3D imaging. So these are the main things that constitute a mitral valve apparatus. We should start with looking at the leaflets. And I would look at the leaflets in the eyes of a surgeon, whether the leaflets allow for a repair or the leaflets need to be replaced. And this depends on how healthy the tissue is for doing an edge-to-edge repair or not. We also want to look at leaflet calcification. Moving on to the annulus, we want to look at the primary annular pathology. Is it dilatation driven or is it calcification? And if there is dilatation or calcification, what is the extent of that? When it comes to MAC, we want to look at the distribution of MAC. Is it focal? And what is the focal extension of MAC? And we also want to look at how circumferential the MAC distribution is. Then we want to look at the subvalvular apparatus. Is there tethering of the mitral valve leaflets? And if there is tethering, is it tethering both the anterior or the posterior leaflet? Sometimes you just see posterior leaflet being tethered more than the anterior. And these are important nuances to pick up at baseline evaluation. We also want to look at subvalvular thickening and calcification because this plays an important role in TMVR delivery of the device. Then we look at the left ventricle. If it is the primary driver of pathology, as in secondary mitral regurgitation, because the devices may be different or limited in those cases, and heart failure management may be the first step in most of these patients. If we are dealing with the opposite end of the spectrum, that is small left ventricles, these also pose an issue. These are usually seen in patients with mitral stenosis, severe MAC, small ladies with big atria. So these patients have small ventricles, and this may be an issue when you're delivering your TMVR devices as there is interaction with the delivery system. And last but not the least, we want to look at the left ventricular outflow tract because this will help us decide whether replacement is feasible or not. So when we are looking at the mitral valve apparatus, we want to answer these main questions. Is it a repairable device or does it need replacement? And what are the procedural risks? Looking at the mitral valve leaflet anatomy, we want to look at the mitral valve leaflet, and everyone knows about the red, yellow, and red zones. The green zones are the patients who have central pathology. Their leaflet tissue is healthy enough for repair. As you can see in this example, the patient has mitral regurgitation that is mostly in the A to B2 zone. The leaflets are relatively healthy. There's some degree of MAC, but not extensive. And this patient falls in the yellow zone, and we did an M-tier for it, and with a decent result. But let's look at the opposite end of the spectrum. So this is a patient who falls in the red zone. Here you can see the leaflet tissue is not healthy. There is multiple flared segments. There is a severe mitral annular calcification. There is not enough posterior tissue. This patient had come in with cardiogenic shock in the hospital with severe mitral regurgitation. We did do a TIO procedure, but as you can see, there's that middle jet. There was no grasping zone on the posterior leaflet, and this patient did end up having moderate to severe mitral regurgitation at discharge, then subsequently came back to get mitral valve replacement. So a poor index patient for repair, just looking at the leaflets. Moving on to the annulus, we want to look at the annulus, the size of the annulus. The best way to look at the annulus is a gated contrast CT. This can be looked at with the echocardiogram, but the measurements are more accurate with CT scan. But using MPR 3D echo, you can get accurate measurements of the mitral valve annulus for your baseline study. We want to look at the presence of MAC. Again, this is CT helps us know the true extent of the mitral annular calcification as well as the circumferentiality. And we also have to remember when it comes to the annulus is not a rigid structure. As the ventricle contracts, the annulus becomes more of a saddle shape to allow for less stress on the leaflets, to allow blood flow from the atrium to the ventricle and from the ventricle out. So we want to make sure that we are cognizant of the fact that the annulus is not a rigid structure when we are choosing our device. CT for mitral valve interventions has now become baseline modality for imaging. We want to do this especially for patients who we are considering TMVR devices. Like I mentioned, besides annular sizing, the other things we look at with the CT scan is the landing zone. That can be done using virtual valves, which allows us to put different valves in different positions. We can choose our landing zone, either a little atrial or a little ventricular. We can also angulate it depending on the patient anatomy. We can also get an aortomitral angle, which helps us determine the risk of LVOT obstruction. And it helps us measure the neo-LVOT, as you can see in the right panel there. Ventricular anatomy, you want to look at the entire ventricle. You want to look at the papillary muscles and the papillary muscle displacement, the degree of mitral regurgitation, and also the degree of tenting that is involved here. You can see on the right panel, the leaflets are severely tethered. This patient also had subvalvular thickening and calcification, which is another thing that you want to pay close attention to. Moving on to the complication that is the most important, that keeps us awake quite literally. You will get called multiple times once you have an LVOT obstruction. This is something that we need to study upfront for patients being considered for replacement devices. Here you can see this is a measurement that's done during the end systolic phase. That's your worst case scenario. It can be done throughout systole to see how the LVOT behaves throughout systole. And like Dave previously showed very beautifully, that there are several methods to mitigate left ventricular outflow tract obstruction, starting with alcohol septal ablation. For that, you'll need a cardiac cath to look at septal perforators and the basal septal hypertrophy. Other methods to mitigate this is the Sesame procedure, which is basically laceration of this basal septal hypertrophy to allow for the LVOT to be opened up for TMVR devices. The risk factors for small LVOT are long anterior mitral leaflets, small ventricles, as well as significant basal septal hypertrophy. So moving on from the green, yellow, and red zones, I think now that we have more tools in our toolbox, the thinking has to be shifted towards repair versus replacement. So the green zone will fall towards our repair strategy, whereas the red zone will fall towards our replacement strategy. And now we have so many devices being studied. The TMVR realm is increasing drastically. I think the thought should be repair versus replacement. Moving beyond today's toolbox, there are several devices that are being studied now, such as leaflet augmentation devices. These may be a possible solution for patients who have short leaflets, or they have multiple jets that's usually seen with atrial functional disease, or it may be helpful for either side of the valve, whether it's anterior leaflet or the posterior leaflet. And then we have annuloplasty devices, and these are the patient populations for these devices would be patients who have absolutely normal leaflets, but they have annular dilatation that is driving the pathology. Then we have chordal devices. These allow us to retain all parts of the mitral valve apparatus as well as the movement of the mitral valve annulus. And they just it's just targeted therapy towards the cord that's diseased. And then we have posterior leaflet replacement devices that are being studied that will just replace the posterior part of the mitral valve, leaving the anterior mitral valve leaflet as is. So these may be some of the devices that may help resolve the LVOT issue. So in conclusion, anatomy always determines the treatment. We have to remember that the mitral valve apparatus is dynamic, the mitral valve annulus is dynamic, and future therapy should be targeted towards patient-specific anatomy. And we have to start thinking about lifetime management when we think about interventions for mitral valve. Thank you.
So that was a wonderful overview, Radhika. So do you think we're ready for some trials of repair versus replacement? Has replacement become safe enough in straightforward cases where we can look at this, or is that too soon?
Right now, I would say too soon, but the experience is growing and it's growing fast. So I would say that day is not that far. We are looking at the horizon for that. Yeah.
And who is the population we should be studying in those trials? Is it the COAP trial, green FMR patients, or is it these yellow or red zone patients where we try to push TIR and sometimes the TIR or the anatomy, as you said, pushes back?
So I would say the yellow and the orange zone patients where there is some possibility of TIR, but the result is unpredictable. As you know, the green anatomy is who we know the results are going to be great. Red is who we know the results are not going to be good, but the middle population is who I would think would be the best subjects for a trial like that.
All right. So I just wanted to say, Vratika, that was a beautiful and practical presentation on mitral anatomy. Maybe a last question to Mark. How often do you use CT now for the planning of patients that you consider for transcatheter intervention, mitral interventions? Is it 100% or is it more like selected? That's question number one. And question number two, what is the relative proportion of TIR versus TMVR in your practice today?
So for the first question, I would say, can you hear me okay?
Yeah.
Yeah.
You can hear me? I'm sorry, I look like I'm frozen on my screen. I get CTs on any patient that I'm considering replacing their valve. Because if I'm thinking about surgery for the patient, I'm going to do it minimally invasively. So I want to see what their femoral axis is. It's actually nice to know what their valve size is, whether it's aortic or mitral. The only patients I really don't get a CAT scan on are the functional patients that are low EF that I know that are going to go to clip and we're probably not going to consider for a different option. As far as the breakdown between TIR and replacement, we were a high enroller in M3, and so we had the opportunity to do a fair number of patients. I still think that if you can repair the valve, whether that be catheter-based or surgically, that's preferable. So clip is, if you think you can get a good result with clip, I would probably, or with TIR, I would lean in that direction. But obviously, as there's more experience with M3, we have had a great experience with it. So I think that over time, that proportion will probably increase.
Thank you, Mark. That was a clear answer. So let's move on with the program, and let's go to Andrea, who will walk us through a practical walkthrough of transcatheter edge-to-edge mitral repair. Andrea, over to you.
Thanks, Nicolas. So can I have my slides on? Okay, as you just said, I will use a case presentation to do a practical walkthrough of transcatheter edge-to-edge mitral repair. So I have no disclosures. I'm gonna start by introducing the case. This is a 62-year-old woman that we saw during the past year. She had like common risk factors, as you can see here: hypertension, diabetes, hyperlipidemia, small lady, as you can see in the top right. And she was known for having this history of non-ischemic cardiomyopathy with an ejection fraction of 35%. She also had a left bundle branch block, which is the reason for the implantation of a CRTD. This was in 2013, 13 years ago. And as you can see on the right, all the GDMT was there, including Entresto, Jardiance, Lasix, spironolactone, and beta blocker. So she presented because she was severely short of breath, NYHA class 3. And that's why we started with the workup. The first test I'm going to show you is this transthoracic echocardiography showing the LVF of 35%, which is not new. We knew she had this cardiomyopathy. We can see that the right side, the TRV was normal for both size and function. And she had this that was graded as moderate severe MR, severe in other studies, moderate to severe in others, in any case, significant. In the bottom of the slide, you can see the left and right heart catheterization. There was this incidental finding of a 70% prox RCA stenosis, which was in any case negative on invasive hemodynamic assessment. And for the right heart cath, we had a mean PA pressure of 28 with a wedge of 15, cardiac index that was reduced, 1.65. These were the relevant findings. So now we will clearly these patients had an indication for having this mitral regurgitation corrected. So we proceeded with the evaluation for M-tier. What we will be doing now, we will do it step by step, following this flow chart, and we will see how we help this patient. So step number 1, baseline evaluation. So baseline evaluation is basically done with TE. The goal for TE is, as you can see on the left, to review the mechanism and severity of MR, as Pratika showed you earlier. That's not the only thing. So we also need to look at the mitral valve area, what will be our transeptal puncture height, how long is the posterior leaflet, is there anything in the subvalvular apparatus that should be a concern for us, like dense scores or something else. We can see already here in this case, in the right, the mitral valve area was quantified as 3.2. We have this jet that is very central, coming from a 2P2. So moderate to severe MR. This was due to symmetric mitral valve leaflet tethering and also some mitral annulus dilation. The posterior leaflet was long 12 millimeters with a max fossa height of 38 and a small mitral valve area, 3.2. So this was one of the reasons why we picked the Pascal device for this case. In particular, we decided to try with the P10 device because we think it's really a good device for these small anatomies, especially when we have this so much tethering and small mitral valve areas. Both the nitinol of the Pascal and the spacer, they can help in this kind of anatomies, and we will see it in this case. So step number 2 is we are starting the procedure. First thing is the transeptal puncture. Again, this can be done either in bicaval view or 3D MPR. The important thing is to measure how high we are from the mitral valve plane. Clearly, this is different, the height that we need, if this is a flail or if it's if there is severe tethering, such as in this case. And then another thing that we like to do is using the 3D view that you can see here in the right, so that we can actually localize the puncture in relation to the mitral valve, which is at the bottom. Step number 3, we advance the Pascal guide catheter. We do it under T guidance. Once we are satisfied with the position, we cross from the right to the left atrium. Then we leave more or less 2 centimeters of guide catheter in there, and we pull back both the dilator and the wire. And then we advance the Pascal device delivery. We advance the Pascal device delivery. Another very favorable thing of the Pascal device is that as soon as we come out, we can already bend the device. We can open, close the device. And once we bend downwards to the mitral valve, what we need to use the T for, and all of this is done with 3D MPR, is to make sure we are in the right position, in this case, a 2P2, that we are having the right trajectory, so we are perpendicular to the mitral valve plane, and also that we are oriented in the best way possible, considering the target, because we want to be perpendicular to the coaptation line in the target area. Then we check the clasp. Usually the light gray is always the anterior, dark gray is the posterior, but we make sure here under T, as you can see in the bottom right. And another thing that we like to do even before crossing the valve is this anterior-posterior swing with the guide catheter. So in case we want to optimize the leaflet insertion or we want to do a single device capture, we know how clean is our anterior-posterior movement, and that we are not going too lateral or too medial when we go anterior or posterior. And then with the device open, we cross the mitral valve. And this is step number 5. Once we are done down into the left ventricle, we pull back and we use the T again to confirm the device position and 2P2 and the orientation. Again, we want the two arms of the device being perpendicular to the coaptation plane at the site of grasping. Here we can see we have leaflets on both the anterior and the posterior arm. And at this point, once we are satisfied, we go down with the clasp. We are doing the leaflet grasping. We use the T again to confirm that we have adequate leaflet insertion. And the mobility we can see here, we have bouncing on both the anterior and the posterior side. And this is the moment we need to stop and think if we need to optimize this grasping. In this case, we were very satisfied with the grasping. On the posterior side, we're almost at the annular, at the base of the mitral annulus. So we took it, we didn't optimize this case, and we closed the device. So this is step number 7. We check for device performance. We do it after we close the device. Once the device is closed, we can see on T how much leaflet tissue bridge we have, was the residual MR, was the residual mean gradient, which in this case was, if I'm not wrong, was 3 millimeters of mercury. So it was a very good result. This is also the moment we need to consider if we are going with a single device, or if we need to, if we have significant MR, if we need to abort and maybe move this clip so that we can make space for another device. Clearly, this was not the case. We had like probably trace or mild residual MR with low mean gradients despite this small anatomy. So we decided to release the device. So we released the device, we pulled back the Pascal delivery system, and again, we check for residual MR or mitral valve mean gradients. That's another thing we really like about the Pascal. We don't get like too much surprise after we release the device. It's usually the same, if not better than what we see when we are still attached. Here we see just a trace, like trivial jets, just medial to the Pascal, and again, a very low mean gradient, less than 5. So this is the moment we can still consider if adding another device, but this was not needed in this case. So we go now to the last step of the procedure. We need to check for the iatrogenic ASD, and we need to make a decision, shall we close it or not? David just already covered the indications for closing it after TMVR. I will say here I listed some of them if the defect is very large, because with guide catheter manipulation, maybe we made it larger. If there is bidirectional or right to left shunt, if there is severe TR or RV dysfunction or pulmonary hypertension, these are the cases we tend to close. Just for these cases, just for this case, I added the risk of right to left embolism for one reason. This patient actually on screening had a clot on this ICD lead placed on DOAC. The clot didn't resolve, so we decided to close the septum to prevent any paradoxical embolism from right to left. And another nice thing I want you to pay attention to, if you look at the Pascal here, how nicely it opens and closes during the cardiac cycle. This is a property of the nitinol, which is how the Pascal device is made. And this is probably one of the reasons why this device is very forgiving for these small anatomies. And I'm going to conclude with just the final result from moderate to severe baseline MR. This patient was discharged with trivial trace residual MR, and this was durable up to 1 month when we saw back the patient in clinic. And I stop here.
Thank you very much, Andrea, for this case-based learning of TIR, of how to do TIR in a stepwise approach. Mark, you have, as a surgeon who masters minimal invasive surgical techniques and also does transcatheter therapies, you have a unique position here. How often do you prefer a minimal invasive surgery over transcatheter mitral TIR in patients? Did you hear the question? Sorry.
I missed the last part, but I think I could fill in the blank. I think surgery is still more reliable, and I know that there's various studies who are looking to to provide real evidence to support that statement, one way or the other. But if a patient's a good surgical candidate, mitral valve repair is probably about the best operation that we can offer. It's truly curative. I think it's reliable. But as we get better at clip or at TIR, I do think that there's more opportunity to apply that to a broader group of patients. For patients who are poor surgical candidates, patients who are low EF, I definitely think that the transcatheter options are better. But if you have a normal EF patient who's a good surgical candidate, it's as a surgeon, and obviously I'm biased, I have a hard time saying that I think that there's a better therapy than that.
But does that require minimal invasive techniques, or doesn't that matter to you?
Honestly, I offer minimally invasive therapies for two reasons, particularly related to the mitral. It's better exposure. You're looking right at the mitral valve, whereas with a sternotomy, you're pulling up on the mitral, and I don't think the exposure is good, and it's more palatable to the patients. It's when patients come in for catheter-based therapies, and then they, you have to move them in the direction of surgery. They're much more likely to be agreeable if you can tell them that you'll do it through a small incision. There's usually a little bit of a clarification: is this still open heart surgery? Is it, or is it something else? It's still open heart surgery through a smaller incision, but patients are much more accepting of it.
Yeah. Thank you. All right. So to close our session, we'll head over to Toronto, where we go to a center that is probably one of the highest volume centers in transcatheter mitral and tricuspid intervention. So Neil Moat will give us his perspective on.
Great. Can you hear me? All right. So
Yes.
We can.
Perfect. I'm going to pick up on the topic of MAC because this has come up again and again in this meeting, and there is an unmet need, I would say, in patients with MAC. So this is a 71-year-old woman who has recurrent heart failure hospitalization, remains very symptomatic, and she's got the usual comorbidities of AFib, CKD. She's had a previous stroke with good recovery, no coronary disease, and she has HFpEF with pulmonary hypertension. This is her CT scan, which shows really, really severe MAC MAC that's not just in the annulus, but invading into the myocardium and the leaflets. So I think we can be pretty confident to say this is not an ideal TIR candidate. It's really it's a red case. So here's the TE showing the commissural view, the valve just encased in calcium. You can still see some leaflet motion, but she's got both severe regurgitation and a gradient of 7. So at this point, we're looking to do a replacement. And here's the 3D just showing from above. Now, we certainly have pushed TIR a long way, and I completely agree with all the previous comments that TIR has surpassed expectations and is really a workhorse device to treat many different patients, and is very generalizable, but it's not always feasible. And Dave really presented a nice case of a failed TIR procedure, and someone had MAC and very elegantly found a solution. But I think rather than try to get away with TIR, sometimes we just need to think replacement from the beginning. So just to summarize, MAC causes both mitral stenosis and regurgitation. Sometimes one is dominant over the other. The dedicated TMVR devices are mainly studying patients who have dominant mitral regurgitation or maybe mixed MR with some MS. Majority of the trials are not looking at pure mitral stenosis, and that's another, I would say, challenging group of patients to treat. When we look at this framework of TIR versus replacement, this patient clearly more in the replacement side of the spectrum. So if we just review some of the results with TMVR and MAC, the early experience was using balloon expandable sapien valves in MAC, and most of these registries show 30-day mortality around 20 to 30%, which is very, very sobering. There are some more recent experiences which perhaps are more favorable. And then, of course, with dedicated devices, we have the Tendyne valve, which is a transapical system, lower mortality here, but these are in highly selected patients. And of course, it's a much more morbid procedure when using a transapical approach. And so the challenges of TMVR and MAC are several. Some of these were touched on. Of course, LVOT obstruction is the most feared, and we have ways to mitigate that. There's the risk of embolism and anchoring, and then paravalvular leak. So some of these actually are now addressable, and we're going to go over some of it now. So the dedicated device, which we're looking at here, is the Sapien M3, which Dave introduced very nicely. We have the dock with a PVL guard, and then we have the Sapien M3, which is a 29 millimeter valve that has a skirt along the entire valve to mitigate PVL. So we did touch on the Encircle trial. The Encircle trial had a MAC registry of 100 patients, and we'll be seeing some data presented on that soon. And I'm going to present one of the patients who was in the MAC cohort. So the overall Encircle population, the results were really quite effective. MRs reduced to trace or mild and 95% of the time. And I think the most encouraging thing from the Encircle trial, which was a single-arm study, was that at 30 days, we've got a mortality of 0.7% with a TMVR. And so really what we're starting to see now is clip-like safety with abolishment of MR. So hopefully we're getting the best of both worlds. Now, what we haven't discussed, of course, and those of you who are enrolling in these trials know that screen failure remains a significant challenge with the dedicated devices. But I think now with commercialization, we can start to push the limits a little bit more and learn which patients we can actually treat that were not in the trial. So this is the first step of the procedure, which is encircling subvalvular apparatus. It was actually remarkably straightforward, despite the fact that the subvalvular anatomy was calcified, with thickened cords. But the doc just tends to find its way, and with excellent echo guidance, you can actually do this relatively quickly. And so the short axis view just shows we've gone all the way around, and at this point, the doc is deployed. And subsequently, the sapien is deployed under rapid pacing, just like a valve-in-valve procedure. So, the whole procedure took about an hour and 15 minutes, and the result was very gratifying. So we've eliminated MR. Remarkably, despite the pretty hostile anatomy, we have no PDL, and the patient made an excellent recovery. Actually went home the next day as if she had had a TIO procedure, which I think is one of the things I've seen with Sapien M3 in particular. If the procedure goes well, there's really not much to worry about after, as long as the patient can tolerate anticoagulation. We don't see usually LVOT obstruction because you secure the anterior leaflet. It doesn't paralyze the base of the LV like some other valves do. Holds everything together, including the PAP muscles, and so the LV function also seems to be relatively preserved. So I think TIR is a very safe and effective technique. We use it in many patients, but it's not for all patients. TMVR, I think, has made tremendous progress and is really ready for prime time in high surgical risk patients, and now should be considered in those who are red or even orange for TIR. And then TMVR with MAC with dedicated devices such as M3 is clearly serving an unmet need, and the further advances in tools and technique, as we saw earlier, will expand the treatable population. And with that, I'll thank you. Okay, so let's talk maybe again to Mark. You have Mitral, right? Surgical Sapien and MAC, and now you have access to M3 or high enroller. How do you make that decision?
I mean, for me, I think M3 is just a better option. It's a dedicated device. I've never been overwhelmed with the outcomes related to Sapien and MAC. It's, we did a fair amount early on. Our experience and the published data haven't inspired me to aggressively pursue that. I think that there's I'm optimistic that M3 can help fill that void.
And Andrea and Radhika, any comments? Because I think we're getting close to the end of the session.
Yeah, it's good to have a therapy that can target mitral stenosis, and I think M3 gives us an option to do that. Because that, as you mentioned, it's a challenging population, sometimes too high risk for surgery. So it's good to have an option for that. The screen failure rate still is high, but I think it's good to have an option.
Yes, I agree. I mean, also we should not forget that we had like repair for so many years. So now we push it on very challenging anatomies. So it's probably unfair to compare them now, but I agree with your point that probably in the near future we will get there when we have enough experience with replacement, where we can offer it in more, like say, yellowish anatomies, more towards the green rather than just red zone anatomies. Also, because some of these patients with repair, we don't know how much durable the repair is. While we know that with the valve we get rid of all of it. We also have challenges about the valve, but the only way to know is with these trials that are well done, and with M3 now we can treat many more patients who otherwise had no other options.
I'm curious to know, because you have commercial access to M3 in the US. We don't have it yet in Canada. Are you treating patients who have pure calcific mitral stenosis without regurg?
Yes. So I think like they do encourage us to submit those patients. Even rheumatic mitral stenosis, I was told that it's okay to submit and pending approval from the company.
There were some rheumatics actually treated as part of Encircle. We did a couple, and I was quite impressed with how well it worked. But as Dave said before, in some of these very constrained anatomies, you really have to post-dilate the valve after with a 28 millimeter true balloon, otherwise it doesn't fully expand. So, I mean, for a first generation device, I think it really outperformed expectations. But as you said, we have to fix the screen failure problem. So probably we'll need several different valves on the shelf, or they need to come up with different sizing. But I think the future is pretty bright.
Yeah.
Okay, wonderful. Well, maybe we can close out this session on transcatheter mitral valve intervention. Thanks for joining us at TIO USA, and we'll go on to the next one.
Thank you all.